Welcome to this FCP webinar. It's really great to see you all here tonight. I'm really looking forward to hearing a lot more from our speakers this evening. I'm Izzy Hall, the CSP Student Coordinator. I obviously work closely with students all over the UK. I've only just joined quite recently. A lot of you might know Steph Burns, who I work alongside as well. And we are joined tonight by Hannah Morley, who is CSP Professional Adviser and former FCP. I'll allow her to introduce herself fully though when I pass over to her. And we've also got Chloe Neville with us here, who is a final year student at the University of Wolverhampton. So only a few bits of housekeeping from me, and then we'll get started. You're also used to Zoom, I'm sure you're fine with it, but just in case of any problems, obviously this is about sound. And we really want you to get involved tonight. So we will be doing a few polls. And if you've been on our webinars before, I'm sure you've seen those. Really straightforward, obviously. We've got a little welcome poll for you just to check you're actually all there. So I'm just going to launch this poll, literally just asking what year of your studies you are in. Whether you're first year, second year, third year, or I've added fourth year in case we've got some students from Scotland. Thank you, I can see you're casting your votes at the moment. Oh, it's so speedy, thank you. What a great audience we've got. Give you 10 more seconds. Some of you thinking about which year you're in. That's brilliant, thank you. So I can see it's mostly second years, then first years, then third years, and then we've just got one person who is a fourth year. So, in fact, you can see the results there. So thank you guys, it's really straightforward to use as you'll see. And we're actually going to be using the poll function when we're talking about some case studies towards the end of the webinar, so that you guys can get involved and have a go at thinking of some solutions to the case studies as well. So if you do want to ask any questions though, we've got the Q&A function. Because it's a webinar, we've only got the video and sound enabled for the panelists. But if you do have any questions, just pop those in the Q&A, and there'll be a couple of us who can keep an eye on that and pick them up as we go along if we need to. But we are going to allow some time at the end of the webinar to take some Q&As as well. Right, well, I will now pass over to Hannah, who will tell you obviously a little bit more about her experiences as an FCP, and she's going to tell you all about what it's going to be like. And then she will pass to Chloe, who's going to reflect on her FCP placement that she's done. And then we'll come back to Hannah for some real case studies as well, which I think you're going to find really interesting. Just to let you all know, of course, we are recording. We won't mention anyone's surnames if you do pop a question in the Q&A. Right, thank you, Hannah. I will pass over to you now.
Great, thanks, Izzy. In fact, I'm probably just going to share my screen if that's all right, because then I can do all the controlling from here. There we are. All right. So everyone can see that? People on the panel, give me a hand, a wave if you can. Lovely. Great. Okay. So just wanted to tell you a little bit about me really to begin with. So I'm a CSP Professional Adviser. Actually, my region is Wales. But more importantly, I suppose, for this scenario is that I am a FCP as well. So I've been an FCP for 5 years. I still do that a very small amount, a bit of clinical still, just to keep my hand in. So I wanted to tell you a little bit about what my life has been like as an FCP, but also what my journey has been towards FCP. So this is just a bit of a reflection on some of those sort of career decisions that took me to that point. So obviously I actually graduated in Wales, in Cardiff, and then went and ended up working as an FCP. And my team is here at the bottom. That's myself and my two colleagues that worked in the primary care trust in Gloucestershire. And then also surrounding that, some of the things that we did on a day-to-day basis. So we could send for scans and images, we would order bloods when appropriate. We trained as injection therapists, which is really exciting. It was a really great thing to do, and also trained in non-medical prescribing. So it meant that we could write prescriptions for pain medications for patients. So as you can see, there's a lot of courses and extra skills there. And that is one of the reasons that FCP is something that sort of happens for people autonomously after they've been quite experienced as physios. But also there's lots of experiences there that you can get in the meantime. There's lots of things that you can sort of build up to that. And actually, a lot of the experiences I had in my career built me up to the point where I felt comfortable to do a non-medical prescribing course, where I felt comfortable to work in primary care, felt comfortable to do injection courses and bloods and imaging. So there's lots of experiences that you can get along the way. And this is one of the experiences I was lucky to have. I worked out in Canada. So after graduating and doing some rotations, so band 5 and band 6 rotations as they were at that time, I actually moved over to Vancouver. So Vancouver is one of the very few places, I think, where you can be on the beach and looking at the mountains at the same time, or you can be swimming in the sea and then you can be on the slopes in pretty quick time. But actually in Vancouver, I worked in a big organization. So it's a very big what they're called health authorities there, and that was on a rotational basis, very similar to the rotations I've done here. But then I also specialized in chronic pain while I was there. I took an opportunity to do a maternity leave. So someone else had gone on maternity leave, so I stepped into their post, and that gave me an incredible opportunity to explore an area and see if see what I thought of it. And it was something that I really fell in love with. But then actually, family and other reasons wanted to move back to the UK. So on coming back to the UK, I carried on in that vein, loving chronic pain, and I was able to present at the British Pain Society in Scotland, and also did my master's with Cardiff University in pain management. And at that point, sort of started feeling like I wanted something different, or I wanted something a bit more juicy. And that's when I started looking at First Contact Physio, because actually in primary care, there's a lot of chronic pain. There's a lot of change behavior that you need to use. So you need to have those communication skills that you develop in pain management circles. So I worked across Gloucestershire. That little map at the top is a map of some of the hospitals in Gloucestershire. And I became an advanced practitioner as well. So I worked as part of a musculoskeletal interface service. So those are the services that GPs refer into rather than orthopedics. And we did sort of, that's where I learned about injection therapy. It's where I learned about imaging, and became a member of the APPNs, the Advanced Practice Physiotherapy Network. And after a couple of years working in advanced practice, so interface clinics and FCP, so primary care, having done non-medical prescribing, having done injection therapy, I sort of wanted to explore a bit wider, and was really lucky and very fortunate to be successful in achieving a fellowship. So I got a fellowship with the Winston Churchill Memorial Trust, which allowed me to travel to Australia and New Zealand. So those places in the corner there is where I traveled. And I undertook a study to explore advanced practice, essentially, internationally, so in different areas, and was able to compare and contrast, particularly around what first contact physiotherapy looks like. So when a patient first arrives, what happens to them? So I was able to explore how that had developed in other countries as well. So that's sort of how I arrived at being an FCP in my journey. But an FCP's day looks pretty standard across the country, actually, we know. So for us in our service in Gloucestershire and in the service that I currently lead in Stroud, we start the day with MSK triage phone calls. So pre-pandemic, this would have been a slot of phone calls that we'd be going through to see if we could help the patients over the phone, or to see if we needed to bring them in to see them. Now that's slightly different in that most appointments are over the phone currently, at least initially. So the decisions are slightly different now that we're in the pandemic, and things are changing constantly. But a typical day would have been MSK triage phone calls to start with, to decide what to do with those patients. And within a 20-minute appointment, so whether that is face-to-face, whether that's in person or virtual, remote, you're doing an assessment, you're giving a diagnosis, you're explaining your diagnosis or your opinion, you're offering any investigations that may be required, and also offering an initial treatment options, and certainly offering self-management advice at every opportunity, onward referral if needed. So that's happening in most consultations. Sometimes there's a little bit more of one thing, so a little bit more self-management advice, a little bit more investigation, a little bit less self-management advice, just depending on the condition and the evolution of that condition at that stage. But most patients are getting all of that in their appointment. There's a mixture of in-person and phone calls. So the in-person ones are currently being triaged because of the pandemic. And that totals to about 12 to 17 contacts per day. And that's approximately 70 to 80% of those patients, those contacts you haven't met before. So they're new patients, or they're patients that have previously used the service and have a new problem. On top of those clinical contacts, so the conversations that you're having with the patient, we're also completing outcome data for each patient. So what they came in with, what investigations you did, what the outcome of those investigations has been, have you made any referrals, what advice did you give? That's happening for every patient, because it's really important that we know what happens to these patients, we know how the services are being used. We also check we have an email address for the service, so we're checking that every day to see if patients are contacting us or getting back in touch, because we're finding that email or some apps that are attached to the electronic patient records are quite helpful to send patient information, and sometimes they can reply as well. And we're also checking our task lists. So again, on the electronic patient record system, you can send messages to GPs, to other staff, and they'll send messages back to you. So that might be, Hannah, you ordered a blood test, it's come back in, can you deal with this? Or something like that. So you're checking those every day. So that's what a day in the life of an FCP looks like. This is how we triage our patients. So it's a good way to visualize it is through this traffic light system. Ideally, what we want is for the patient to call the GP practice, they speak to a receptionist, or also called a care navigator, and if they follow correctly through the flowchart on the other side, which I'll go through in a moment, then the receptionist or care navigator offers them an FCP appointment. It says APP there, that means Advanced Physiotherapy Practitioner, but equally this could be FCP. Sometimes it happens that the patient doesn't go directly onto our list, but actually has been triaged for the advanced nurse practitioner or the GP, and then they look through it, they follow the flowchart, and they think they need an FCP appointment. So it comes sort of slightly indirectly, but still first contact. They still haven't been seen by anyone else. But equally, it can be that they end up on the GP or the ANP, the advanced nurse practitioner's list. They get booked in for an appointment with them. That clinician sees them. And potentially that clinician at that point identifies that they're MSK and they'd be better for us, and they perhaps deal with one of the other 10 things that the patient's got on their list. Or sometimes, and this isn't ideal, but perhaps that clinician starts treating that problem or starts giving advice about that problem, and then we get an appointment with them after that. It's not ideal because it's not first contact. It does sometimes create difficulty depending on what's been offered, but those are the things that we do get as well. And although this flowchart is very small, the main thing about it is the body chart that you can see. So you can see the back of the body is completely clear. So pain anywhere on the back of the body, we will see. The front of the body has two redded out areas, blocked out areas. So the face and the chest and the tummy. So we'll see pain anywhere, but if it's on the face, the chest or the tummy, that's not for the physio. That's not for FCP. I don't want to see chest pain. I don't want to see tummy pain. That needs to be seen by a doctor or a specialist nurse. So that's really what we hope that the receptionists can use. And they're very, very good at that. That gives us very good results. And then just finally where they go. So you can see that that big green area is all self-management. So once we've seen the patients, most of them go to be self-managed. There are a couple that, there's very minor there that get imaging. So 4% of them get some X-rays. But you can see that we're doing lots of other things. We're prescribing for our patients. So we're prescribing pain medication. We're doing some injections. We're following some of them up, but not very many. And we're giving fit notes. So that's about getting them back to work. There's a lot of other things that are going on as well, but those are the main bits. And looking at, so that's a year at a glance in that big pie chart we looked at. Looking at a month in a glance, these are all the places that patients were referred to from the physio. So a lot actually go, 13% go back into general physio because they do need physio, they need rehab. Not all of them need rehab. Some of them need specialist input, so some go to specialists in the hospital, and we have some going to A&E for different reasons. We have some going to pain clinics, some going to interface services, but we also have a lot of community referrals, so to different specialists within primary care or to different specialists within the community. So that sort of explains where our referrals come from and also where they go, and also what we do in our day and how I sort of got there. So I hope that's helpful. That's all of my slides. So I think I'll hand over to Chloe to tell you a bit about what her experience was like.
Thanks, Hannah. We're just going to go back to the main slides and then Chloe will be able to talk through those. So Chloe, if you just want to introduce yourself on getting the slides up, that'd be brilliant.
Hello everyone, my name's Chloe Neville. I'm a third year physiotherapy student and I study at the University of Wolverhampton. I'm due to graduate very soon and I had an FCP placement last year now, just before the COVID pandemic started in the UK. So yes, lovely to meet you all. I'm just going to sort of talk you through my reflections on my FCP placement that I have. So just going into the presentation now, if that's okay, Izzy.
There, can you see that all right, Chloe?
That's absolutely fine, thank you.
Brilliant. Okay, your volume is a little bit low. I don't know whether you could possibly
I'll come closer to my screen. Is that
yeah,
better?
that's better. Yeah. Perfect. Brilliant.
Okay, so in terms of what I knew before about sort of FCP and that type of role, I wasn't actually aware of the role. When I sort of first started my first year of physio, I wasn't really aware of the emerging role, obviously with it being such a new advancing area of physiotherapy practice. But a GP surgery actually did come into my uni and they just spoke about the FCP placements that they were offering for students. A student in the cohort in the year above me actually had an FCP placement with this GP surgery, so they shared their experiences as well and what it was like to be a student in this FCP role. They offered information on the role, sort of the daily duties, responsibilities of the FCPs and why it would be beneficial for students to explore. Obviously, with it being a expertise sort of area of physiotherapy and an advancing sort of area of physio, I was interested to see sort of what I could learn as a student from it. But that's what was really helpful and really sort of interested me in the subject. The student actually spoke about his experience as well, so what he was doing on a day-to-day basis, which gave me an insight into what I might be doing should I get a FCP placement. In terms of preparing for my placement itself, I started looking at the website of the GP surgery that I was placed at. So luckily it was actually the surgery that came in to speak into my university, so that was really helpful, as I already had sort of an insight into what they were doing, but I wanted to gather a bit more information on the surgery, the different sort of clinicians that worked there, just gather a bit of information on that so I was aware of what was going on there. In terms of revision for the role itself, for the placement itself, I obviously revised the core MSK areas that you would revise for any sort of MSK sort of area of placement. I revised all of those areas. I revised the treatments for sort of generalised sort of conditions that you might see and red flags, because that was really highlighted upon from the student that spoke in the talk with the GP surgery. So I really went over those red flags. I revised the full body, really focused in on the shoulder, the knee and the spinal revision though, because that's what they were mentioning quite a lot of. So I assume that that might be the sort of the conditions and the sort of areas of the body that I might be assessing the most. So that's the revision I did, and if you could go into the next slide, please, Izzy, if that's okay. And then in terms of what I actually did as a student on the placement, not only did I work with the FCP, but I also worked with a varied sort of different clinicians and different practice staff during my time there. I'm not sure if this is the same on every FCP placement, but this is what I experienced. I had the opportunity to shadow GPs and see their role in the practice and sort of how things differed with how the GPs assessed and obviously the FCPs assessed for different things. I shadowed nurses and the advanced nurse practitioner and sort of had a look at what they did. I shadowed the urgent care practitioner. I went out on home visits with him, which was really interesting to see their role in the practice as well. I also helped out with the open days, so things like the asthma open days, diabetes open days, which again just helped to build my confidence, even with things like communication and communicating with patients. I also shadowed the healthy lifestyles team as well. And this was really useful because after sort of shadowing this service, this healthy lifestyle service, I was then actually able to use the knowledge that I'd gained from that to then be able to refer patients on who were appropriate for that service when I was actually seeing patients as a student. So that was really, really helpful. It was also really helpful to shadow the reception and administration staff, obviously with them being the first point of contact, the very, very first point of contact for a patient as they ring up to get their actual appointment. It was really interesting to see how they screened and the training that they'd received to be able to screen for the appropriateness of an FCP or a GP for them to see their condition. So that was just sort of the generalised practice staff that I worked with. In terms of the appointments themselves, obviously, as Hannah has already mentioned, you have a 20-minute appointment with an FCP, and it was a face-to-face appointment at that time because obviously COVID hadn't quite hit at that point. As a student, we were given a little bit more leeway. We were given 25 minutes, which was really helpful. So it gave us that little bit more time, obviously with it being such a fast-paced environment, to be able to assess and obviously go through all of our different assessments, objective assessments that we do. In terms of documentation, it was SOAP notes, the same as obviously you would in a normal MSK placement. SOAP notes documentation, we did our documentation online, but obviously that can vary depending on where you are. But obviously with it being a GP practice, that's how GPs would write their notes online. The FCPs were no different, they wrote their notes online as well. In terms of the actual assessments and things that we were using during the appointment times, obviously you have far less time than you would with a MSK outpatient placement, for example. So it was really focusing in on sort of being able to choose the most appropriate objective assessments based on the presenting complaints, based on the subjective history that the patient has been telling you. So during that due to that limited time, we really had the opportunity to explore our development in terms of being able to choose the right assessments for the right time. So that was really helpful. And also we learned a lot about referrals. So we were writing referrals all the time, obviously, as Hannah has mentioned as well, obviously being a triage service as well. We were able to write referrals and explore different services that we were actually able to refer patients onto. And by exploring those services, it really gave me more of a sort of knowledge of the best places to refer patients onto. So obviously referrals for things like outpatient physio, pain services, imaging, investigations, so blood tests, things like that. In terms of the CPD and everything else that we had to do for the placement, as you would in any placement, you obviously have to do your continuous professional development folder that you would do. So I did that as normal and did my reflections within that. But I also found that on this placement, due to it being so fast-paced and a really different and new environment for me, I actually did a logbook as well and sort of wrote down what I'd seen on each day and just some small reflections on what I'd found from working with different people and seeing different patients and different conditions. And it's really useful to look back on as well, sort of to see what I did and everything that I explored during that placement. And then obviously just your normal reflections that you would and your research that you would do for your CPD folder. In terms of the setting that we had during my time there, obviously, as I've mentioned, it was before the COVID pandemic. So we had face-to-face appointments, but I know students in my cohort that have been there since COVID hit, and they have changed to virtual appointments now. But as I said, that didn't affect my time there, but people that I've spoken to who have been in that situation where it's been virtual appointments, obviously it's a really different environment. Students that are on the call who have sort of had placements will know any sort of placements in the outpatient environment have been very different since COVID has hit. So it's interesting actually to see the difference in sort of the assessments and things like that that you can explore, and really reining in on that subjective assessment to be able to get the information you need as a FCP kind of student placement. In terms of the challenges that I faced during the placement, I've mentioned a few times it's quite different from the traditional MSK setting. So you have far shorter appointment times, sort of less time to explore different assessments and things like that. So it was really fast paced. So it was really trying to get used to that during the time. I was there for 4 weeks. So it just gave me just enough time really to get used to the sort of fast-paced environment of the FCP role, and it really just helped me to explore and to be more confident in choosing assessments and things like that. So that's what I did on my placement. And if I can have the next slide, please, Izzy. Could I have the next slide, please, Izzy? Thank you. Okay, so in terms of the reflections in my personal experience of the placement, in terms of my expectations of the FCP role and the FCP placement as a student physio, it did meet my expectations, and this was actually due to the fact that the GP practice had come in and had actually spoken to us and sort of gave us an insight already into the role itself and what our day would be like as a student. So I had sort of some ideas and some expectations, and it did meet that, and it did go beyond that. I was very impressed with the placement and everything that I gained and everything that I learned from it. I would say overall I gained a really good insight into the role and how it fits into the primary care setting as well. So how it fits in around the GPs and the other clinicians, and it really fits into that role. Obviously, with me not exploring that role before, it was really good to see actually how everything worked whilst I was there. It was also good to see how the FCP worked with the GP as well. So things like prescribing medication. So the FCP that I was working with wasn't able to prescribe some medication. So it was interesting to see how they communicated and how they worked with the GP to obviously provide that care for the patients. In terms of the FCP role itself and the importance of red flags, I really, on this placement, gained an understanding of how important it actually is to screen for these red flags, for these more serious pathologies. So we had a couple of occasions where we had to take emergency action for obviously screening for cauda equina. So it was interesting and a good learning experience to see obviously that occur and how that all planned out and the steps to take in that situation. So it was a good learning point, and obviously how you communicate with the patient in that setting as well and in that circumstance. Obviously it can be quite distressing for the patient, so it's obviously just learning and developing your communication skills in that area as well. Yeah, so otherwise as well, sort of safety netting as well for the patient. So learning how to safety net, and obviously that means obviously making sure that the patient knows that should they get these symptoms that could suggest serious pathology such as cauda equina, that they are aware and they know what to do in that circumstance. So obviously encouraging them to take ownership of their own care in that circumstance. So it was really good for developing myself there as well. In terms of clinical skills, I really developed my assessment skills. Obviously, as I've mentioned, fast-paced environment, developing your assessment skills, making sure that you're getting everything that you need in that appointment time to be able to make that decision of what to do from there. So do you refer on? What do you do in that circumstance? So it was really good to develop myself there. Clinical reasoning skills, obviously, again, leading on from that, making that decision on perhaps is there a diagnosis that we can give? Do we need to refer for imaging? What are we going to do in that circumstance? So really think about my clinical reasoning skills, what they're telling me in the objective, what they're telling me in the subjective appointment, subjective questions. So that was really useful. In terms of whether I'd like to explore FCP in the future, I would say definitely yes. Obviously, it's an advancing area in physiotherapy practice. It's an area that you would go in when you're a bit more specialised in the MSK setting and the MSK role. It gives physiotherapists a development opportunity, so things like improving your scope of practice and really advancing your skills as a physiotherapist. So it gives you opportunities such as learning injection therapy. I know that Hannah's already mentioned that. Imaging, and obviously feeding back on the imaging results and the reports. Blood test results, so that's a different area that you would be feeding back on that you might not sort of get to explore in different environments of physiotherapy. So that was really interesting as well to sort of learn about blood tests and things like that whilst I was on placement. As well, independent prescribing, it gives that opportunity for physiotherapists to again advance their scope of practice in terms of independent prescribing and things like that. to be an FCP, there is a roadmap, and I will be exploring that more in the future so that I'm able to develop my skills and qualities that are needed. There is a 14-point capability framework that was developed by Health Education England to make sure that FCPs are equipped for their role. And I will be exploring that once I'm qualified, and obviously gaining more experience in an MSK setting to become more specialised in that role. But it's definitely something that I would like to go into in the future, and it was really good to have that insight so that I've gained that interest, and I've developed that interest and want to explore it further. So it was really good as a student to have that opportunity. And if I could just have the last slide, if that's okay, Izzy. So my advice to anyone on this call, any students who are watching back, who are thinking about taking an FCP placement, I would advise it's definitely a great learning opportunity, and I really would sort of stress that you take the opportunity if you have it, and if it's something that you want to explore and maybe universities haven't mentioned it, really mention it to your lecturer. Say, I'm interested in this FCP role, are there any placement opportunities? So if it's something you're interested in, definitely explore it. It's definitely worth it. It was really insightful to see the job opportunities that I might have in the future once I've obviously gained experience. I've got an opportunity to see the advances in physiotherapy practice as well, and how physiotherapy and practice might sort of pan out for us as students in the future, and what we'll be exploring as we go through our career. It was really interesting to see that. How it meets the needs of contemporary practice as well. So things like the NHS long-term plan, improving primary care services, bringing first contact practitioners into primary care to sort of be expertise, give their expertise and knowledge of MSK conditions and treat them, and really how it meets that contemporary practice as we move forward through the years. It gives you a chance to develop your clinical assessment and intervention skills. Obviously, that fast-paced environment really gives you the opportunity to really go for it with these skills and really sort of intensify your learning experience in this area. Obviously, that opportunity to develop your communication skills as well as you would in any placement. It's a really good opportunity for that, especially with your subjective questioning as well. It gives you opportunity to develop your ability to educate patients on imagery, blood test results, health promotion. So some things that you might not get an opportunity in other areas for. Health promotion, obviously, really important in terms of contemporary practice and making every contact count, supporting behaviour for change. So that was really important, and that's really something that you would get the opportunity to do on an FCP placement. It also gives you the ability to explore different services that you can refer patients onto. As I've mentioned, it gave me the opportunity to really sort of learn about the best places to be referring patients onto to give them the best quality care, and sort of really learning that from sort of being a student will help me in the future as I go into my professional career. So I think that's really important as well, to have that knowledge of other services so that you're able to offer and make this accessible for patients. And also, finally, just an opportunity to experience a different side to MSK physiotherapy. So just that different environment to your traditional outpatient setting. Just a different opportunity, new things to explore. It was just a really, really good placement overall, and I can't stress enough that it's really important, especially if it's something that you're thinking about going into in the future or something that you're interested in. It was just a really great opportunity. So yes, brilliant placement. And thank you for listening, and I will hand back over to Hannah as well now if she's ready.
Thanks, Chloe, that was amazing. It's such a great chance for other students to hear about your placement, your reflections and your advice for them as well. So a huge thank you from us to Chloe. We would like to invite anybody to put questions into the Q&A. If you've got any questions for Chloe about her placement, or if you have any questions for Hannah as well, if you pop those into the Q&A, then we'll know, whether we need to leave a bit more time at the end after the case studies. So we will keep an eye on that. Thanks, Hannah. I'll pass over to you now.
Great, thank you. Thanks, Chloe. That was really wonderful to hear about your experiences as well. It sounds like you had a really good team around you, so that's fab. And you may have come across some of the things that we're going to now talk about. So I've got a couple of case studies lined up for us, and there are also a few polls, so do pay attention. So these case studies will come up line by line, so you shouldn't get the answers ahead of time. So Izzy, if you want to just work through as you go. So case study 1, we've got a patient with thoracic pain. Carry on. Right, here we go. So she's a 70-year-old lady, known osteoporosis. So that medication there is a medication that we use for people that have known osteoporosis. So it's a prophylactic medication to help manage that. Okay, so that she had that thoracic pain after moving house the previous day. So she'd come into clinic, and she's talking about upper back pain. She's an elderly lady with osteoporosis, and she's putting it down to the fact that she moved house yesterday. So we're going to launch a poll now and see what you think of that. So first one you're going to answer is number 1. So far, without any more information, what are your suspicions? What do you think might be going on already with just that little bit of information? You can only make one choice.
Thank you to the first person who voted. Top marks. Brilliant. Thank you, guys.
Izzy, can you see them coming in?
Yes.
There's some people thinking hard about it.
They are, yes. But we got about half of the attendees have responded, so well done, and it's rising still.
Thank you. So remember, you've got a lady, old elderly lady, 70 years old, known osteoporosis with thoracic pain after moving house the day before. What are you concerned about? What are your thoughts? So does she have muscle pain from moving house? Has she got a shoulder injury from lifting the boxes? Do you think she's got a fractured rib? Do you think she's got a vertebral fracture?
And we've also got question 2 here. What does the FCP do next?
Don't worry about question 2 just yet.
Oh, we've got quite a lot of replies.
Oh, okay. All right. All right. Should we give you a bit more information so that you can answer question 2 a bit easier?
Yeah, let's keep the poll open then.
Okay.
And,
all right. Well, feel free to add to question 2 as you get a bit more information. So we've also got... Okay, so the next thing I did, because this is quite a detailed one, is this is a patient I saw, so I ordered her a thoracic X-ray. And that confirmed the answer to question 1, she had a vertebral fracture. So she had a vertebral fracture of osteoporotic collapse, T7 on T8.
well done, 61% of you who got that right.
Really, that is fantastic. Gosh, well done, because there was a little bit of a red herring in there. The moving house, it was actually an old vertebral collapse. So we could tell from the X-ray that it wasn't due to her moving house. Probably the pain was caused, it was stirred up by the fact that she moved house, but the vertebral collapse wasn't caused by that. Okay. But the next bit is that I called to discuss the results with her, and the pain had moved. Pain was no longer in her thoracic spine, but it had moved from her thoracic spine to her breast. And she also reported weight loss. Okay, so now I want you to think about what you would do next at this point. So this is where I want you to answer question number 2. So we've found out that she's come in with thoracic pain and she's got a vertebral collapse. But now the pain's moved. She's now got breast pain and she's now reporting weight loss. So perhaps your concerns are different now. So think about that, what your concerns now might be, and what might I have done at this stage. So if you answered before having that information, you might have a different opinion now. So don't worry about that. But what do you think I did next?
Just give that a few more seconds.
Yeah, I can. Someone saying that question 1 and question 2 came in the same poll.
5, 4, 3, 2, 1. Okay.
Yeah.
Right, I'm going to share the results. There we go. Can you see that, Hannah?
Yeah. Okay. Yeah, I think actually that was quite confusing in that question 1 and question 2 came up at the same point before you had the added information. So you're absolutely right in that at that first decision point where I thought she had a vertebral fracture, what I did is I ordered an X-ray. Now with that new information that the pain had moved to her breast and also she'd had weight loss, actually the next thing is that I sent for some bloods. Okay, because we dealt with the vertebral fracture. Now we know what that is now. So you all did brilliantly to identify the vertebral fracture because I didn't give you the rest of the information. Okay, so if we close that poll and let's get the rest of the case study up. So that's the information about her pain moving. That's where the poll 2 comes in. So what I did was I sent for bloods. Now these bloods show that there is some inflammation and that something's happening in the body that we're not expecting. So platelets means that something's being produced that we're not expecting. So that, for me, is I've done my bit as the physio, as the FCPs. I've identified there's something I'm concerned about. I've acted on it as soon as I can, but actually the next thing is not for me, because I'm sure you can all imagine what I'm concerned about. Could you bring up the rest of the points there for me, Izzy? I discussed it with GP. He sent for a chest X-ray. And he also referred to what we call his 2-week wait. So that means if there's a concern that you might have a new cancer diagnosis, so that's now what I'm concerned about, as I'm concerned this lady might have breast cancer, the GP referred to breast clinic for the 2-week wait. She had an abnormal chest X-ray come back and it showed that she had lesions on her lung. So she had cancerous lesions on her lung and she was awaiting a CT thorax. That's like a higher resolution image. So essentially this lady ended up having breast cancer and it was identified from her thoracic pain. It was sort of identified from her thoracic pain as an indirect, because if she hadn't have had pain from moving house, she wouldn't have come to us and ended up with the thoracic X-ray. I wouldn't have called her and then she wouldn't have told me that the pain had moved. So all of those things are so important that you keep on your toes in FCP, because you never know what's going to come through the door. But that is why thoracic pain is always one of those things that it gets a flag going for us, and you all identified that really well. So that's great. So we can move on to the second case study, I think. Now, let's just see, were there any questions particularly about that before we move on? John says question 1 and question 2 came up on the same poll, so we can't answer them separately. Fair enough, fair enough. There are a couple more like that actually, so we'll bear that in mind as we go through. Okay, thank you for that. As an FCP, are you able to refer for a chest X-ray or is it situationally dependent? No, I can't order a chest X-ray because it's not a musculoskeletal. So I could order the thoracic one, but then I talked to the GP, they had the same suspicions, so they then took over the care. So that's me saying this is no longer MSK. I actually need to speak to someone about this and I need to hand over that duty of care to someone that can take those actions. In some areas, it may be that the local pathway means that you can, but I would say in the majority of cases, regardless of what the pathway says, it's taking that back to the GP. But actually in my situation, we couldn't have ordered a chest X-ray because the restrictions are for MSK only. Right. So this case study is about the evolution of problems that come into come into primary care. Because sometimes when you're in outpatients, for example, the problem arrives and it's been there for 9 months, say. So you think it's done all its evolution it can do, or at least to a certain point. Whereas in primary care, like that last lady, she arrived the day she had her pain. You know, she moved yesterday, today she arrived with pain, and actually it changed. So this patient attended the clinic from Care Navigators, so they spoke to a receptionist first. Okay, 10 out of 10 back pain. This is a gentleman, he's in his mid-40s, he's a manual worker, and he's got 10 out of 10 back pain. He is really, really suffering. And you can tell as he's moving, you can really see it. It is really, really awful. He's also on methotrexate, which is quite important to note. That is a steroid. And he's on it for a skin condition, okay? Out of interest, the next point is that he's attended A&E twice and he was discharged home from A&E. He was actually discharged home to his parents' house because he didn't want to be by himself. He felt like he couldn't walk well and he was too unwell, so he went back to his parents' house from A&E. And then he came to the FCP service the next day. So he'd already been to A&E twice, been discharged home, stayed at his parents' house. He woke up that morning and his parents said to him, absolutely, you need to get this seen to. We're not taking you back to A&E, you need to go to the doctor. So he came into my clinic. So he's describing 10 out of 10 pain. He's also sweating and feeling really nauseous. He's bright red, he's sweating all the way down his forehead. So I take his temperature because he looks awful and I think, wow, this man is boiling up. So I took his temperature, very high temperature. But when I assess him, no objective changes for neurology. But he's guarding, he's really holding everything on. So no objective changes apart from the temperature, but he's really pain guarding. Now I'm just going to see what poll 2 is on my notes because they might come up at the same time.
We've got, what are the concerning features of this presentation? Pick all that are applicable. Is that right, Hannah?
Yes, is that coming up just as the first poll?
Just
perfect.
that.
Yes, that. Lovely. I don't want to give you the answers.
So this is multiple choice.
All right. So please pick all the things that are applicable that you thought as I was talking through that, you thought to yourself, oh my gosh, I wouldn't want to see that person because of that. I hope there's a lot of clicking going on. There's a lot of scary things. There's a lot of scary things in this case study. Okay.
Okay, I'll give you 10 more seconds. This is good. Okay. No, people are still thinking about it. Okay, 5, 4, 3, 2, 1. I'll end the poll now and share the results.
Fantastic. This is fantastic. Gosh, look at that. So yes, you're absolutely right. The nausea and the high temperature, that actually indicates a systemic problem, doesn't it? So that's why I think you're all very concerned about that. But you're equally right that everything else is concerning. Yeah, even the mid-40s, this is his, I perhaps didn't frame this correctly, in that this is his first incidence of back pain in his mid-40s. I'm not too concerned about him being a manual worker, I'll be honest. If he'd have come and said I'm a manual worker and I fell off scaffolding yesterday, that would increase my concern. But with being a manual worker, that's not too concerning. The methotrexate, now I did give you a bit of a clue with this one, but that is a huge concern. Methotrexate is a steroid, and that makes it more likely that he might have a systemic problem. Okay. And yes, the pain guarding is important. The multiple attendances, that's not ever really noted in textbooks or lectures or anything like that as a concern. It's not a red flag as such, but I was concerned about that. This man has felt it is that extreme that he's gone to A&E twice, and also he didn't feel like he could be alone. This is a man in his 40s with a full-time job as a manual worker, and he didn't feel he could be alone because he felt that unwell. So that certainly raised my concern levels. So yeah, you all did brilliant there. Okay, so what did I do next? So literally from my treatment room, after taking his temperature, I left the chap where he was, had someone keep an eye on him, and I went out and found the duty doctor. And I said, I've got this chap with me. I'm really concerned about him. I need you to, please, can you see him? And she said, absolutely, bring him over to me right now. And she saw him within about 10 minutes of that appointment. And she prescribed him naproxen, which is an anti-inflammatory, and she prescribed him Zapane, so that's a version of cocodamol. And she also ordered some blood tests, and he was sent home. He went back to stay at his parents that night. The next morning, the patient came back. He reattended. And so he called back in the GP the next morning as soon as the GP practice opened. And how GP practices work is it depends what you say to the receptionist, depending on where they put you. So obviously the day before he'd said back pain, so they put him in with me. And this time he was saying, I'm unwell, I need to see someone straight away. So the quickest person was the nurse. So they put him on the nurse list. And she phoned him and he said to her, I've got weakness. Now, they didn't say that to the receptionist. He said that to the nurse. So he's now gone through a receptionist, through a nurse. he says weakness. So she books him straight in with the GP for that day. He comes into the clinic, and the GP said to me afterwards, and this is actually what she wrote down on the notes, that he walked into clinic like he had cerebral palsy. He had a neurological gait. He was dragging his leg. He couldn't walk very well at all. And what's significant about that is he did not look like that when I saw him the day before. He was sweating, he was pain guarding, he had a high temperature, but his walking, despite the fact he was in a lot of pain, was okay. So she admitted him to A&E that day. Okay. He was then transferred to neurosurgery for emergency surgery and IV antibiotics. So, what do you think it was? It's a tricky question. It's a tricky question.
Well done. The responses are coming really quickly now.
Okay, think about the fact that he had a high temperature. He was systemically unwell. We don't see many of these. You know, even FCPs might see 1 or 0 in their career. So if you've not seen it before or known about it before, don't worry. Okay.
Just give it a few more seconds.
A few more seconds.
Yeah. Okay, let's end there.
I'm excited about this one. Oh my gosh, that is brilliant. Well done, everyone. 60%. Yes, he had discitis. Yeah, absolutely. And you know, it's not completely different to say cord equine syndrome, because he did have neuro signs, didn't he? So for some people that thought cord equine, I can completely understand why you went there. And you know, but the difference with the cord equina is they don't have the high temperature necessarily. But what would have got you to cord equina was probably the gait, and the weakness would have got you to feeling like that, to thinking it might have been that. Yeah, and the weakness might have been why you thought about the stroke as well. I can understand that. But yeah, discitis is what he had, and luckily he went straight over to A&E. Was, like I said, he was sent straight to neurosurgery and had treatment for that. Okay. Whew, hotting up, right. So have we got any questions coming in, Izzy? For people are just really involved, aren't they? Really just thinking about the studies. Okay, let's go to number 3 then.
I think that was the last one.
Oh, well, I can give you a number 3. If you give me a moment. Okay. What have we got? Have we got enough time for a number 3?
Yeah, we've got time.
Okay, all right.
Almost everybody voted, so obviously they like getting involved. It's a really nice way to do, isn't it? You know, to have the involvement.
Really nice. Okay. And have a think about any questions that you want to ask as well. While you've got Chloe here, who's obviously experienced a placement in FCP, you know, I can try and answer any questions that you might have about the sort of evolution of FCP or what it's like to work in practice. Just have a little think about that and pop those in the chat.
Yeah, please do put your questions in the Q&A. And just to confirm, we are recording this session, so we will send it out. It'll probably be Monday now when we send it out to everybody, along with any useful links that are sent on by Chloe and Hannah. And if anyone's got any questions in the meantime, you can always contact us through the Student Inquiries mailbox. So it's studentinquiries@csp.org.uk. I'll put that in the chat pod as well, just so you've got that there.
Okay. Right, I'm going to just talk you through this, okay? And if I think of any polls in the meantime, you can put your answers in the chat, okay?
I was going to say, I can probably do a quick poll.
All right, let's see how we get on. Okay, so we've got a patient with ankle pain that comes in. She's a middle, I think she was in her 60s, this lady. Yeah, she was about in her 60s. And she's coming with ankle pain. She was booked in to see me from the care navigators. So again, she's not seen anyone else, first of all. So just like you would with your GP, when you call up, they tend to ask you, what are you calling about? And remember, the care navigators will have gone through that flow chart that I showed you initially. As long as it's not head pain, chest pain, or tummy pain, they can book in with the physio, with the first contact physio. So they were booked in that way, and she came in with ankle pain. So that's what she told the receptionist. On assessment, so when I looked at her, it wasn't really ankle pain, it was ankle and calf pain on one side. Okay. Now, in the GP surgery, you can see all of the history. So I can see all of the medical records, and I can see that this lady has a history of DVT. Okay, I can see, I'm sure that was inching into some people's heads already. Yeah, and that's what we're all thinking about, isn't it, with that ankle pain? So she had a history of DVT. Now, I was then able to carry out what's called a well score, which is just something that we can do to see how concerned I am that it might be a DVT. Now, she'd already had one in the past, so that makes it more likely. She wasn't on any medication prophylactically, so that means to sort of stop it happening again. And she had calf pain. Yeah. The other things that you look for, of course, are swelling and redness, but pain, swelling and redness. So again, just like that previous chap, what's really brilliant about being in primary care is I can come out of my room. I wasn't concerned this lady was going to suddenly deteriorate. So I come out of my room, I knock on the GP's door who's on duty, and I say, I think I've got the lady with a DVT. And so they immediately were able to come out and see the lady. So the lady went back into the waiting area. She was watched by the receptionist. The GP calls her in, and they were then able to confirm the Wells score, and they started her on a medication straight away to break down the potential clot. And then they ordered the investigations that were necessary. And this lady, it was determined that she did have a DVT, and she's now on lifelong anticoagulants, so blood thinning medication. And what I really like about that case study is that if that had happened to me in a outpatient setting, there are a few more steps. I have to call the GP or send her to A&E. But actually in primary care, although, you know, some people do feel like they're potentially isolated being only physio in the GP practice, but actually it's so much more accessible for those medical emergencies. And the amount of times that I've asked a question that didn't turn out to be a medical emergency, you know, the ones I've shared with you did turn out to be medical emergencies, but there are many that don't. But you have access to that medical knowledge, which is wonderful. And it makes it a really smooth system, and really smooth system for the patients as well. Okay, so I didn't have a question there because it all came out all at once. Let me see if there's anything to get you thinking in this one. Okay, I've got a question in this one. Are there any questions coming in? Let's have a look.
Sorry to interrupt, Hannah. I think I can do this as a poll. As you say it to me, I'll pop it into the poll and type up the answers, and then I'll share it, and just hopefully that'll work.
All right, yeah, because we like the polls, don't we? Okay.
Yeah, it's nice to see how everyone's voted. It's much easier in the chat.
All right, so this was a lady actually again with multiple joint pains, and she'd attended A&E. She'd also attended out of hours, so that's when you call your GP practice out. You call 111 normally, and then they said you need to see a GP straight away, and you can't wait to see your GP in the morning. So she'd attended A&E, she'd attended out of hours. She'd also had a phone call with an advanced nurse practitioner. So there's lots of interventions going on here on the build up to seeing me. And in the notes from the A&P, she's got hand swelling and pain in both hands. So we've got multiple joint pains, hand swelling, and hand pain in both hands. So the question is, what are you suspicious of? Are you suspicious that she might have osteoarthritis? Are you suspicious that she might have rheumatoid arthritis, so OA or RA? Are you suspicious that she might have a repetitive strain injury, RSI? How are you doing with that, Izzy?
Thanks for the abbreviation. I was going to say, please excuse my spelling, but yeah. Okay, we're happy with those three as single choice. Okay, now let's see whether we can launch it. Bear with me a second. There we go. Launch the poll.
Brilliant. Okay, so remember, this lady has multiple joint pains. She's been to A&E, she's been to out of hours, she's been to the nurse. She's told the nurse that she's got hand swelling and hand pain. So has she got osteoarthritis, rheumatoid arthritis, or some sort of repetitive strain injury?
This is really interesting. Everybody's voting for the same option.
Let's hope you're all suspicious of the right thing.
Okay, just give it a few more seconds.
Yeah, bilateral, yeah. Both hands.
Okay, we'll end the poll now and share the results.
Fantastic. Yes, that is what I was suspicious of. Are you amazed at how brilliant physio students are already?
I'm not surprised at all. I know they're amazing.
They are fantastic, you guys. You've absolutely got it. And yes, those people that voted for OA, you're absolutely right in that people can get exacerbations of arthritis, osteoarthritis in their hands, and that can absolutely be the reason for it. But in First Contact Physio, my concern is, what is the worst thing that could be going on here? And then I whittle it down from there. Yeah, so you're thinking about the worst case scenario. So that's absolutely what I was thinking, is I was thinking she might have RA. So what I was able to do then was organize bloods for her. So there's a specific type of bloods that you need to organize for that suspicion, to sort of rule out other things. And then actually she'd already been referred, by the time the blood results came back, she'd been referred to rheumatology. But in our local health region, in our area, we actually have a specialist clinic. Some of you might have heard of this, called Early Inflammatory Arthritis Clinic. And that's for these people who have previously not been diagnosed with an inflammatory arthritis. And it's to get them in quickly, because if you start treatment early, it can really help the prognosis. It can help how well they function afterwards. So the rheumatology appointment that she'd already been referred for, that was 9 months waiting, but we were able to get her in 3 weeks. And actually I had to do a bit of education after that, because that pathway wasn't widely known to the rest of the team. So what we did there is we didn't only get that lady in quickly to be seen in the right place, but we were also able to share that learning across the MDT as well. All right. That's
Hannah,
all.
would you like to pick up those questions that are in the Q&A?
Brilliant. Yeah, because I was going to say, you really have to rack my brain for any others. I haven't prepared any others, so I know you're really all enjoying it, but let's take a few questions. So we've got someone asking, how much experience do you need to start to train as an FCP? So Chloe mentioned the roadmap earlier, and the FCP roadmap is something that is launched in England, but it's relevant for the other countries as well, because it does give a really good framework. And that roadmap is very clear about how long you need to be practicing for, or what's best practice before you step into an FCP role. So I would definitely recommend having a look at that. But certainly you can start understanding more about FCP, even now. Chloe's done a placement in FCP and has learned an awful lot, as she shared with us. So you can certainly start to learn about FCP from whatever stage you're at now. When you think about being a new graduate, there are always opportunities to think about primary care, to think about liaising with GPs, to start building your understanding of what primary care is like. But there are aspects that, you do need to acknowledge need that level of experience. So, it's really important to get a good, well-rounded amount of experience. So, for example, with that chat we talked about with the discitis, you need to be comfortable with taking objective assessments, so doing the temperature, you need to be doing the OBS, that sort of thing, and knowing when a patient is acutely unwell. So it's really good not just to necessarily focus in one area straight away, but to get a really well-rounded training. So I would say that those are some key things. So there's not necessarily an amount of time that you can start training, but it's about really being aware of, if this is something you want to pursue, getting that well-rounded education and training in lots of different areas, and also thinking about checking in with primary care options, community options, when you're in different areas of work. Okay, and actually, I think I just saw something, yeah. Maya's just popped in the chat there a link to the roadmap. So that's got lots of detail about the sorts of competencies that FCPs are looking for. So, and then the other question here by Arash is, can you advise on a career path not as challenging as yours to become an FCP? Mine just was a bit wiggly, that's all, Arash, that's all. There was lots of mountains and sea on the way, so I wouldn't say that bit was challenging. Exactly the same sort of answer there, really. It is about getting that way rounded. It's not about going from A to B in an absolute dead straight line and sort of trying to bosh through it as such, because you do need to have that broad range of experience. So I would say that definitely look at the roadmap, because that's a really good guide, but there's lots of things that you can explore in the meantime. Yes, there are quicker ways to get there probably than I did, but I was able to explore some things I really loved in the meantime. And sometimes you don't know which areas you'd like to work in until you've sort of explored a couple of them. So yeah, there's certainly lots of options there. And Sam is asking, do you require a master's or PhD? And if so, what would you advise? So it is important that you work towards master's level, absolutely. And as you'll see in the roadmap, you do need to have a level 7, which is a master's level, in order to practice as an FCP. And that will certainly be the case by the time those of you that are currently students are looking at FCP roles, but that's to be an autonomous FCP. You know, it may be that you can do shadowing experiences, it may be that there'll be developmental opportunities in aspects of work that you're involved in, and it's certainly a good opportunity to think about other ways to involve yourself in primary care prior to, you know, I don't want people to think the first time they arrive in primary care is once they've been trained X number of years and have got a master's. You know, it's okay for you to think about being in primary care, but of course you wouldn't necessarily want to be making those decisions autonomously until you've done some extra study, until you've got that level 7, so that critical thinking and all those different experiences as well. And if so, what would you advise? There are actually lots of modules being developed currently for FCPs specifically. So the training that I did was injection therapy, non-medical prescribing, and also I did a master's in pain management. But at the time when I was studying, there wasn't an FCP module available, and they are looking fantastic, and they're coming out now as well. So those are master's modules that will be available by the time you guys are looking for that sort of thing. Does the master's degree have to be specifically an MSK physio, or can a master's pre-reg physio degree be okay? It is a relevant master's, so it's either a FCP module or a relevant master's, which would be MSK. Yeah, and that's again because if you're doing a pre-reg master's degree, it's just in reflection that you perhaps haven't had that opportunity to fully explore and get experiences in all the different areas that you want to develop in order to be able to face those sort of difficult types of patients. Okay. And Sam's saying, I'm in my final year at Keele and I understand they have an ACP Masters. Yes. Okay, brilliant. Thank you for that, Sam. ACP Masters, that's Advanced Clinical Practitioner. Absolutely. So FCP means First Contact Practitioner or First Contact Physio. You can also be an advanced practitioner in First Contact Physio. Not every First Contact Physio will necessarily be so, but absolutely an Advanced Clinical Practice Masters would give you lots of scope for this sort of role, and often they're multidisciplinary as well, so there'll be other people on that masters that you'll get other experiences from. For example, my non-medical prescribing course was multi-professional, so I met lots of paramedics, lots of nurses, and it's really good to get that learning experience that's quite broad as well. Brilliant. Yeah, and there's also, I would definitely recommend, there's things in the chat there from Izzy to everybody about our pages on FCP. So if this has really sparked your interest, we've got lots and lots of information on the CSP website about First Contact Physio, and it's definitely worth delving in there and having a little look. And also, if you wanted to even watch this back as well, if you wanted to have another go at those case studies, then you can always watch it back. Okay.
Thanks, Hannah. I'm just going to pop a quick poll now for everybody in the final minute, just with an evaluation of the webinar. I'd really appreciate it if you could please complete that for us. As I've put in the chat pod, we will be sending out the recording at the beginning of next week, along with any other useful links or information that we've got. Thank you all so much for joining tonight. It's been fantastic. I feel like I've learned a lot. So thank you so much to our panelists, Hannah, and to Chloe as well. Fantastic. And I can see, obviously, everybody's really enjoyed it. So thank you very much, everybody, for joining us. If you do have any other questions and would like to reach out to us, you can always reach us on social media at the CSP Students, or drop us an email, studentinquiries@csp.org.uk. Thanks very much and take care. Enjoy the rest of your evening, everybody. Really great to see you tonight. Thank you for joining us. And if anyone wants to join, we've got a webinar next Thursday night about frailty in older people, which will be a really interesting one that's being hosted by Alicia from the Student Reference Group, along with Justine from Agile, which is one of the professional networks, one of the CSP's networks. So that's really, that'll be really interesting. It's a great program, which is also, obviously, you can book that on Eventbrite, and that's next Thursday evening, a little bit later on in the evening. And yeah, just keep an eye on the website as well, and ICSP for all things CSP student. As I say, enjoy the rest of your evening, and thank you so much for joining us tonight.